I'm Dr. Dipali Gotey. My topic for today's presentation is labor analgesia. We are going to cover following points in this lecture: labor pain pathway, various methods of labor pain relief, details about epidural labor analgesia, various methods of providing it, drugs used in it, various drug regimes used for labor analgesia, benefits of it, certain complications and contraindications, and some troubleshooters providing this service. And finally, the labor analgesia practice in India. Labor is a series of events that take place in genital organ in an effort to expel fetus out of uterus through vagina. According to McGill's pain questionnaire, it is rated as more painful than cancer pain and equivalent to digital amputation. So we all know that amputation of digit is going to require anesthesia. So why not labor pain? The labor pain has pathway originates from uterus and cervix and the perineal structures. So in first stage, pain is mainly visceral and it originates from over uterine segment and cervix. It is mainly because of uterine contraction and stretching and distension of cervix. It is carried to T10 to L1 segment. And in second stage, it is a somatic pain that is because of passage of baby through vaginal canal and causing pressure on vaginal perineal structures. It is mainly carried to S2 to S4 segments. This pain causes serious effects on a mother as well as the fetus. Untreated labor pain causes sympathetic stimulation, hyperventilation and hypoventilation episodes in mother, leads to increase in free fatty acids, raised glucose levels in blood, metabolic acidosis, uterine contraction, vasoconstriction, decrease in placental blood flow, and maternal hypoxia, which in turn leads to fetal acidosis and fetal hypoxia. In long term, it leads to chronic pain and postpartum stress syndrome in mother. If we provide a good analgesia, these deleterious effects on fetus as well as mother can be avoided. So labor analgesia improves maternal well-being and overall birthing experience and satisfaction in mother. On 16th October 1846, WTG Morden used ether for anesthesia. 6 months after that, J.Y. Simpson used diethyl ether for childbirth. He called it as etherization of childbirth. Various concerns were raised on ethical and moral issues of averting this pain. Charles Meg, he proposed that any drug which will abolish pain will also alter contraction and will affect the well-being of a child. Paul Weifel, he detected chloroform in umbilical cord of newborn and proposed that labor analgesia is deleterious for the fetus. In 1857, when John Snow used chloroform for the birth of Prince Leopold, he popularized the procedure. For next 50 years, inhalational agents became popular for providing labor analgesia. In 1940, Halday used regional anesthesia and later it became gold standard for providing analgesia. Ideal labor analgesic should have minimal to no effect on mother and fetus. It should be easy to administer and monitor and should preserve uterine contractility, progression of labor, and maternal expulsive effort. And it should also facilitate surgical anesthesia. Various methods which are used for labor pain relief are regional and non-regional. In non-regional, the various methods are systemic opioid, inhalational analgesics, non-pharmacological techniques are acupuncture, TENS, hypnotherapy, hydrotherapy. Non-neuraxial techniques are paracervical block and pudendal block, and neuraxial techniques are epidural, continuous spinal epidural. So in systemic opioids, systemic analgesics, mainly opioids are used. They are either long-acting opioids or short-acting opioids. So we all know long-acting opioids are going to cause significant neonatal depression. Pethidine is most popular worldwide, used as a 50 to 100 milligram every 3 hourly. But the drawback is that fetal T-half is very long, that is 13 to 23 hours, causes neonatal depression and also has a neurotoxic metabolite. Fentanyl is much popular. It is short acting, doesn't have any active metabolite and has minimal to no fetal depression. So it is used as 1 microgram per kg bolus. Peak occurs in 3 to 5 minutes and the T-half is 20 to 30 minutes. Remifentanil is newer agent and it is an ultra short acting agent. It is popular for as a PCA pump where the patient can take a bolus of 0.3 to 0.7 microgram on demand and the PCA pump is set at a lockout interval of 2 to 4 minutes. Apart from these agents, tramadol, pentazocine, ketamine, these are less popular, and dexmedetomidine, which is a newer agent but not FDA approved. Internox was used in 1961 and it became this popular worldwide, can be used by midwives in UK. It is a mixture of 50 to 50% of nitrous and oxygen. The advantage is that it is a good analgesic, can be administered by the parturient, but the disadvantage is it causes nausea, vomiting, and dizziness. Other agents that are used like sevoflurane, isoflurane, dose of 0.5 to 0.8%, trilene and methoxyflurane are obsolete now. So according to Cochrane review of 2012, inhalational agents relieve pain without adversely increasing forceps delivery rate, vacuum rate, LSCS rate, or affecting neonatal well-being, but they have a side effect of nausea, vomiting, and drowsiness. Various non-pharmacological techniques are lama, TENS, hydrotherapy, acupuncture, aromatherapy, and intradermal distilled water injections. Coming to regional technique, in first stage of labor, paracervical block provides analgesia, where block is 1% of around 20 ml of lignocaine is used. It is given 1 centimeter under the mucosa of cervicovaginal junction at 4 and 8 o'clock position. And in second stage, pudendal nerve block helps, where the block is given either transvaginally or perineally into the pudendal nerve, which lies just below the ischial spine. Coming to epidural analgesia, among all the methods of labor analgesia, it is considered as a best trick. So efficacy is, if we see the efficacy pyramid, it is epidural is the best. Say has provided certain guidelines to provide epidural analgesia. They propose that it should be initiated and maintained at a location where resuscitation equipments are available. It should be provided by an anesthetist and should be administered only after thorough clinical examination of patient by an obstetrician who can perform operative vaginal or cesarean section. IV infusion should always be present. Fetal and maternal monitoring should always be present. Standard monitoring should always be present. Qualified anesthetist, and in addition to that, a person who can resuscitate neonate should always be present. The anesthetists are generally called to provide labor analgesia services at various centers. How do we do it? Before starting the procedure, we should always do a thorough pre-anesthesia checkup of the patient. We should always take an informed consent, and we should always check the setup for presence of resuscitation equipments, working anesthesia table, presence of IV access, oxygen supply, monitors, emergency drugs. The suction should always be present, and the staff should be well educated about the procedure. So, when to administer an epidural? In the past, they had proposed that it should not be started in early in labor, but after 5 centimeter dilatation when head is properly descended. We are using low concentration drugs which do not affect perineal muscle tone or affect or the motor power of patient and do not prolong the labor. So we can insert it at any time. According to ACOG, maternal request is the correct. We all know there are various anatomical and physiological changes that mother gains weight, edema over back, epidural spaces are vascular, so there is always a risk of bloody tap. Ligaments are very soft. Loss of resistance to find the epidural space is difficult. Inserting an epidural catheter in a pregnant woman is difficult. We can do it in either a lateral or sitting position, and generally L1, L2 is preferred. The epidural space is identified with loss of resistance of air or NS. Recently, we are using sonography to locate the space and depth of the epidural space. We fix the catheter at 3 to 5 centimeters, check the epidural with test dose, and then give the analgesic dose. Test dose should be given. Some say it can be avoided. 2% lignocaine with 1:2 lakh epinephrine, 2 to 3 ml should be given to rule out intrathecal intravascular placement. So after giving a test dose, we should select various drugs which are used are local anesthetics, opioids, and some other drugs. Local anesthetic most commonly used is bupivacaine in a concentration of 0.0625% to 0.125%. Bupivacaine and levobupivacaine, they are levoenantiomer, they are less cardiotoxic, less potent than bupivacaine, so they cause less motor block. Rupivacaine is used in a concentration of 0.1 to 0.2% and levobupivacaine in a concentration of 0.0625 to 0.125%. Studies have found that equal doses of levobupivacaine and ropivacaine, they produce less motor block and more sensory motor separation. Opioids can be used alone intrathecally, or they can be used in combination of local anesthetics either intrathecally or epidurally. Main side effect of local anesthetic is pruritus and dose dependent respiratory depression. Most common additive that we use is fentanyl in a concentration of 10 to 25 milligram intrathecally or 1 to 2 microgram per ml with local anesthetic in epidural. Fentanyl is used in a concentration of 2.5 to 10 microgram intrathecally and 0.5 to 1 microgram per kg per ml with local anesthesia. So morphine, pethidine, these are long-acting agents. They are used, but they are not used more commonly. Other agents that are used are dexmedetomidine, clonidine, and neostigmine. Most commonly used local anesthetic and opioid in India are bupivacaine and fentanyl. So when they are used in combination, they provide superior analgesia. Various combinations that we are using are low dose mixture, ultralight epidural mixture epidural new, and ropivacaine epidural new. How to give the first dose? 10 to 15 ml of 0.0625 to 0.1% bupivacaine with 2 mics per ml of fentanyl should be added, and it should be injected slowly. That is, whole 15 ml should not be injected at the same time. It should be injected as 3 to 5 ml in 3 to 5 ml aliquots over 10 minutes. After giving the first dose, we should assess the pain relief in 20 minutes. The volume of first dose should be adjusted to get VAS score of 2 to 3 after 20 minutes. In the past, concentration used was higher and volume was lesser. But now we are using a lower concentration and higher volume, because as we can see, A delta and C fiber, which carry the pain, they are more sensitive to local anesthetic. So at lower concentration, we can block them. Whereas the motor fibers, they are less sensitive to local anesthetic. So at lower concentration, they are not going to get blocked. We can get a good analgesia, but no motor block at lower concentration and higher volume. Also, the lower concentration reduces incidence of assisted vaginal delivery. It shortens second stage duration, and there is less motor block and urinary retention. After giving first dose, start with intermittent bolus at fixed interval. The bolus is given at a fixed interval of around 40 to 60 minutes. If patient complains of breakthrough pain, 50% of initial dose can be administered in between. The next dose should be given at again a fixed interval. Other methods are bolus on demand. So instead of giving at fixed interval, we are going to give the bolus when patient complains of slight pain. In continuous infusion, we will start the infusion of around 10 to 12 ml per hour with the help of infusion pump or elastomeric pump. Various newer techniques, superior techniques are PCEA, patient control epidural analgesia, PCA with background continuous infusion, automated intermittent mandatory boluses, program intermittent mandatory epidural boluses, and computer integrated PCA. PCA is a device in which we give the patient intermittent boluses. The advantage is that patient can self-administer these boluses with the help of a remote. So we can give background infusion with intermittent bolus through the device. So we set infusion rate, background infusion rate. We set bolus volume that will be delivered through the remote, and we set the lockout interval to prevent multiple boluses or local anesthesia toxicity. In computer integrated PCA, computer program analyzes previous hours required boluses by patient and accordingly changes the background infusion rate. And it can also change the intermittent bolus dose. Apart from epidural analgesia, there are other neuraxial techniques which are even superior to epidural analgesia. So these are combined spinal epidural analgesia, dural puncture epidural analgesia, continuous spinal analgesia, and single shot spinal anesthesia. In combined spinal epidural analgesia, we locate the epidural space with the help of epidural needle, and through the needle we insert a spinal needle to puncture the dura. And in subarachnoid space, we inject analgesic dose of local anesthetic and opioid, and after that we thread the catheter through epidural space. It is useful in early or late stages of labor. So in very early stage, it is useful because we can give an intrathecal dose of only opioid, and the patient will get the relief for around 2 to 3 hours. Patient can also walk during that period because there is no motor block, and it is popular as walking epidural. And in the very late stages, because of pain, patient is not able to position for epidural catheter insertion. So at that time, single intrathecal dose is going to relieve pain. Further procedure becomes easy. It is a superior analgesia procedure. It has less supplemental epidural boluses. It also has lesser rate of catheter failure. Side effects are fetal bradycardia, pruritus, and hypotension. So they say that during analgesia, there is decrease in norepinephrine level and imbalance of norepinephrine and epinephrine level in the body. In dural puncture epidural technique, we locate the epidural space with the needle, and after that we puncture the dura with the help of spinal needle. So we do not give any drug in the spinal subarachnoid space, but we inject drug in the epidural space. So it slowly diffuses into the subarachnoid space because of the puncture in the dura. It gives a rapid onset analgesia. It gives more of symmetrical block and has less maternal and fetal side effects. So there is a one study which compares epidural, dural puncture, and combined spinal epidural techniques. According to this study, onset quickest in case of combined spinal epidural. Need for top-ups is least with dural puncture epidural technique. The side effects are least with dural puncture epidural. So another technique is continuous spinal analgesia, where microcatheter of 28 to 32 gauge is inserted into subarachnoid space. Analgesic dose of local anesthetic and opioid are injected through it. It was restricted in 1992 because of reports of cauda equina. It is a very useful technique in morbidly obese or cardiac disease patients or with patients with previous spinal surgery. Nowadays, it is considered in patients with accidental dural puncture, where keeping the continuous spinal catheter reduces the incidence of PDPH. The dose that should be given in the continuous spinal catheter is 1/10 of the epidural dose. Single shot spinal analgesia, it is useful in late stages of labor where delivery is imminent in 30 to 40 minutes. So it is going to provide quick analgesia, and the dose that we are giving through the spinal is 1 to 1.5 milligram of bupivacaine with 10 to 25 microgram of fentanyl. This is an example of how drugs should be given epidurally. In lumbar epidural, we can give an initial bolus of 10 to 15 milligram of low dose mixture. Maintenance can given with intermittent boluses of 10 to 15 ml. Continuous basal infusion can also be given with 5 to 8 ml per hour. Bolus can be given as and when required. Various regimes are followed with PCA, combined spinal epidural, and CSA regimes. Absolute contraindications for the procedure: patient refusal, raised ICP, infection at the site of insertion, coagulopathy, and hypovolemic shock. Various complications of the procedure: immediate complications are misplaced injection, that is intravascular, intrathecal, or subdural injection, high or total spinal block, hypotension, local anesthesia induced toxicity leading to convulsion and cardiac arrest. Delayed complications are postdural puncture headache, transient backache, urinary retention, epidural hematoma, meningitis, and permanent neurological deficit. How epidural analgesia is beneficial? As we have seen, it prevents the sympathetic stimulation, which helps in normalization of uterine contractions. It allows, because patient becomes pain free, patient allows early use of urotonic, which in turn leads to shortening of duration of labor. It also decreases incidence of LSCS, decreases the cost of LSCS hospital stay for patient. It improves the well-being of fetus. It is very useful in high risk cases and early breastfeeding. Special cases, epidural is very useful. So in heart disease patients, epidural is going to help by reducing the sympathetic stimulation. In PIH patients also, it is going to help controlling the blood pressure. In diabetic patients, the babies are big, forceps or vent use is going to be easy. Premature and IUGR babies, again the uterine contractions are going to get regularized, hypoxia prevented. It is going to be helpful in for the baby in premature and IUGR cases. In multiple pregnancies, again application of forceps and vent use becomes easy. In IUFD, process becomes painless for the mother who is already in distress. In obese parturient, again application of forceps use becomes easy. According to Royal College of Anesthetists, they propose that there should be equal analgesia within 45 minutes of epidural, and more than 98% of patients should be satisfied with epidural pain relief on follow-up visit. Of manipulation or resiting of epidural should be less than 15%. Various problems we face are extensive block, partial analgesia, no analgesia at all. Patient was having good pain relief, but sometimes complaints of inadequate pain relief. That is, working epidural is failed. Patient is converted into LSCS. After giving first dose, if we get an extensive block, so we should check how the analgesia is. Patient has good analgesia but has motor block and hypotension. We should suspect that the epidural is intrathecal. If patient has no analgesia with high block and the cervical segments are also blocked, then catheter is most likely subdural. In this case, we should remove the catheter and resite. Also, the high spinal level should be managed. The first dose, if the patient complains of partial analgesia, one should assess whether it is unilateral, segmental, or there is sacral sparing. So, various reasons for partial block, there are either epidural related or obstetric causes. In epidural causes, either the dose which we are giving is inadequate, or the spread is inadequate, the volume is inadequate, or the catheter is not in place. The various obstetric causes for your partial block, it is occipito-posterior position, transverse lie, scar dehiscence, or full bladder. We are getting a partial block after first dose. We should ask the obstetrician to check for these conditions, and we should also check our epidural. How to manage it? So either we can remove the catheter by 1 centimeter, give the local anesthetic volume and check whether we are getting analgesia or not. We can also increase the volume or concentration of local anesthetic. So if there is no effect, we should replace it. After first dose, the patient is not having any analgesia. Catheter is either subcutaneous or intravascular. If it is intravascular catheter and we are getting no aspiration of blood, we can lead into local anesthesia toxicity because of repeated boluses of local anesthetic. So if we are suspecting that it is a intravascular catheter, we should give a numbing dose where we are giving 5 ml of 1% lignocaine. So lignocaine, if goes intravascularly, it is not going to cause any harm. Epidural was working for 2 boluses. Now it is not work. Could be because the demand has increased or the catheter has migrated. Demand increases in cases of rapidly progressive labor, occipito-posterior position, second stage of labor, or in case of full bladder. In these cases, we should manage the problem with using higher volume and concentration and bladder catheterization. If the epidural analgesia is to be converted into epidural anesthesia for LSCS, patient can be categorized in 4 groups, where in first group there is immediate section has to be done. That is, there is threat to mother and fetus. In category 2, we have fetus and mother has compromised, but there is no immediate life threatening situation. In category 3 and 4, we have sufficient time for converting the analgesia into surgical anesthesia. So how to manage these cases? In category 1, we don't have time, so we should assess the epidural first epidural block. If we don't have any block, we should immediately convert it into general anesthesia. But if we have a block, we should give rapid acting local anesthetic for surgical anesthesia. And if we get a satisfactory level, proceed for LSCS. If we don't get any satisfactory level, directly convert it into general anesthesia. In category 2, if we are not having a good block, we can give a trial of rapid sequence spinal or go for general anesthesia. In category 3, we have sufficient time to assess the block. We can either replace epidural if it is not working, give a combined spinal epidural. If there is no block at all, we can go for single shot spinal. In India, the labor practice is very less. The average incidence and practice of labor analgesia is only 11%. So why so low? There are multiple factors. The patient factors are that is they are not aware of the procedure. The obstetricians factors that they believe that this process increases rate of cesarean section, it increases the rate of instrumental delivery, it prolongs the labor and affects the fetus. Anesthetists, they are also not willing because it is a time consuming process. Wages which we receive are less. Various trials conducted by ACOG and ASA have published a Cochrane database that resolve these misconceptions that there is no direct relationship between epidural and increased cesarean section. Low dose epidural infusion is associated with negligible incidence of instrumental vaginal delivery, and there is no prolongation of any stage of labor. ACOG guideline of 2015, they reiterate that seeking labor analgesia is the right of every woman, and it's the duty of obstetricians and anesthetists to fulfill their dream of painless delivery. Delivery of infant into the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments of medicine. We are privileged to provide this happiness to the mother. Thank you.